So this is the Population, Family, and Reproductive Health Master's Essay Presentations. We are in session 3. I'm Susan Gross, and today we'll be hearing presentations from 4 of our MSPH graduating students. Today we'll start with Ridhima Luthra. Ridhima comes to us with a bachelor's of dental surgery in dentistry from Maharashtra University in Health Sciences. Her area of interest is maternal, fetal, and perinatal health, and today her essay is entitled Systematic Review and Meta-Analysis, Perinatal Oral Health and Pregnancy Complications in the United States from 2003 to 2023. All right, Ridhima, you take it away.
Yeah, thank you, Dr. Gross. So good afternoon, everyone. My name is Ridhima Luthra, and my master's essay topic is Systematic Review and Meta-Analysis, Perinatal Oral Health and Pregnancy Complications in the United States, and I'll be presenting on the same today. Before beginning, I would like to thank my reader, Dr. Saifuddin Ahmed, for his relentless support and mentorship. I would also like to thank my advisor, Dr. Susan Gross, for being the pillar of support throughout my master's journey. And lastly, I would like to thank all the faculty members and my family and friends without whom this journey would have been impossible. This will be my outline that I'll be focusing in my presentation today. A quick introduction about the relationship of oral infections and pregnancy complications. Although the exact mechanism remains uncertain, according to the most commonly proposed mechanism, oral infection acts as a source of pathogenic inflammatory bacteria, which then spreads to amniotic cavity, causing bacteremia, premature induction of labor, and reduction of growth factors. To give a little background, the United States is facing persistently high rates of infant mortality rates amongst all other peer nations. According to a recent statistics, infant mortality rate in the United States is 5.6 deaths per 1,000 live birth. Preterm birth and low birth weight are the second most common causes of infant mortality in US. Despite spending almost 17% of its GDP on healthcare, which is the highest in the world, the US continues to exhibit inferior health outcomes. Given the concerning statistics, there is an urgent need to identify modifiable risk factors for infant mortality and reduce the burden of infant mortality rate. Recent decades have seen growing focus on investigating the relationship between oral infections during pregnancy and their impact on pregnancy complications like preterm birth and low birth weight. Given this background, the objectives of our systematic review was, first, to evaluate the association between oral infections during pregnancy and the risk of adverse pregnancy outcomes such as preterm birth and low birth weight. Secondly, to investigate the safety and effectiveness of oral treatment during pregnancy in reducing the incidence of adverse pregnancy complications. We used PRISMA 2020 guidelines and checklists to conduct our review. Using PubMed, Embase, CINAHL+, and Web of Science, we conducted a literature search in October 2023. We limited the review to studies conducted within the last 20 years to ensure that it captures the most recent understanding of perinatal oral health and its complications, incorporating recent advancement in research methodologies. We included the studies that were conducted in US, published in peer-reviewed journals, used study designs such as randomized controlled trial, cohort study, or case control study, and presented original data on the relationship between perinatal oral health and pregnancy complications. Studies were excluded if they were systematic reviews, scoping reviews, white papers, or only presented qualitative data. We also evaluated the quality of all included studies using adapted Downs and Black scoring method. Additionally, we performed risk of bias assessment for RCTs using ROB2 tool, which is a revised version of the Cochrane risk of bias assessment tool, and for observational studies using Robbins-E tool. Lastly, we used data to conduct two different types of meta-analysis based on our two objectives. Moving on to the results, the initial search yielded a total of 2493 articles across all databases. After removing duplicates, title and abstract screening was conducted for 479 articles. Following a thorough review of the full text for 68 articles, 15 articles were included for data abstraction and analysis. Our first meta-analysis of observational studies revealed a significant association between perinatal oral infection and an increased likelihood of preterm birth with a substantial elevation in risk. The pooled odds ratio was 1.92. Conversely, our meta-analysis of RCTs revealed a trend towards reducing the odds of preterm birth by almost 25%. However, these findings did not achieve statistical significance. Additionally, various themes emerged from the findings of all the included studies. 9 studies had their predominant study population as African American and/or Hispanics, with the percentage being as high as 80% of the entire sample. 13 studies had their study population from southeastern or northeastern region of the United States, which included the states of North Carolina, Alabama, Pennsylvania, and New York. Preterm birth and low birth weight emerged as the most frequently evaluated adverse pregnancy outcome, highlighting their association with oral infections. Approximately half of these studies were intervention studies, while the remaining comprised of cohort studies or case control studies. And lastly, most studies focused on evaluating the impact of periodontal infection on adverse birth outcomes, underscoring the prevalence of this oral health concern during pregnancy. Moving on to our discussion, our meta-analysis of randomized controlled trials reported a reduction in the odds of preterm birth following non-surgical periodontal treatment. However, these results did not achieve statistical significance, possibly due to several inconsistencies among the studies. First, most RCTs included in the analysis administered only a single session of the treatment without subsequent periodontal examination.
Asked about moving. Were you there?
I did too.
Oh,
Without subsequent periodontal examinations until delivery. Given the chronic nature of periodontal disease, multiple treatment sessions are typically necessary for effective management. Secondly, variations in the timing of the treatment across the studies were observed. While all studies administered treatment during second trimester, some provided treatment early in the second trimester, while others administered it later. Administering treatment early in pregnancy may contribute to reduced inflammation at an earlier stage, potentially lowering the odds of preterm birth. Lastly, variations were noted across study regarding the status of periodontal health at the time of enrollment. Some studies included women with mild periodontal disease, while others enrolled women with moderate to severe disease. Administering treatment in the early stages of the disease before it has progressed significantly can substantially decrease the odds of preterm birth. Overall, our results offer valuable insights into the potential influence of oral health interventions during prenatal period on the risk of preterm birth. However, further research is needed to fully understand the clinical significance of non-surgical periodontal treatment. Despite the increasing awareness of the importance of prenatal oral health care, pregnant women face substantial barriers when seeking dental services during pregnancy. These barriers include reluctance from dental providers to administer care during pregnancy, often opting to postpone treatment until delivery. Additionally, challenges such as limited education and awareness, restricted dental coverage in Medicaid programs, inadequate coordination between medical and dental providers for referrals, as well as difficulty in locating Medicaid participating dentists are some of the other concerns. Alarmingly, as of 2022, only 25 states and the District of Columbia offer comprehensive dental coverage under Medicaid during pregnancy. Further, our findings also have various clinical and policy implications. Regarding the clinical implications, first, managing oral infections during pregnancy could potentially reduce the risk of adverse birth outcome, notably preterm birth. Incorporating routine periodontal assessment and customized treatment strategies, especially for pregnant women with moderate to severe disease, holds promise for enhancing birth outcome. Moreover, our analysis emphasizes the safety of dental procedures during pregnancy, offering confidence to healthcare providers and expectant individuals, thereby promoting the timely pursuit of essential dental care. Furthermore, our findings underscore several critical policy recommendations. Firstly, it is imperative to invest in further research to address existing research gaps and ascertain the potential of treatment in significantly reducing adverse pregnancy complications. Secondly, there is a pressing need to enhance awareness among pregnant women and their families regarding the importance of oral health care during pregnancy. Thirdly, comprehensive Medicaid coverage for dental services throughout pregnancy should be urgently implemented across all states in the United States to ensure equitable access to dental care. Finally, efforts must be made to enhance coordination and referral systems between medical and dental providers to streamline care delivery for pregnant individuals. Thank you so much.
Thank you, Ridhima. Great job. Any questions? Please raise your hand or just unmute if you want to ask a question. Can I ask a question then?
Sure.
I know we've talked about this many times, but dental health is a major concern in the WIC program. And I often have many of my participants tell me that they won't get the procedure until after birth because can you tell me what would cause a provider to restrict treatment until after birth?
So previously, there were several myths about administering local anesthesia to pregnant women or performing X-rays or performing other procedures. That's why dental providers usually used to refer the pregnant women to first their gynecologist provider and get their consent first before administering treatment. So that's why that myth still remains. But then there are a lot of awareness research conferences that are happening to enhance awareness of dental providers to share that research has shown that all the dental procedures are considered safe. Of course, there are some restrictions about which antibiotics you can give and what kind of anesthesia you can give. But then overall, research has shown that all kinds of treatment, it's not just second trimester, it's safe in first trimester as well as third trimester. Only challenge with third trimester is pregnant women might find it challenging to be lying in the dental chair for a long time. So that's the only concern. Otherwise, research has shown that it's absolutely safe. Yeah. Hope that answers.
Thank you. So Emily Lasher has a question. What are the potential mechanisms by which oral health status increases risk of preterm birth and other pregnancy complications?
Yes, sure. So as I mentioned, in the beginning showed that slide, that how during pregnancy, because of the hormonal changes, women becomes more prone to getting periodontal infection. And once women gets periodontal infection, the bacteria present in the oral infection has the potential to cross the placenta and reach the amniotic cavity and thereby causing bacteremia. And through release of various interleukins and cytotoxins, it has the potential to cause preterm birth, like premature labor, or reduction in growth factors, so all those factors. Of course, also I wanted to highlight that so there have been various mechanisms that have been proposed. So there's not one universally accepted mechanism, but then this is the one that I shared. That's the most commonly cited mechanism of how oral infection can cause these pregnancy complications.
Kristen, do we have time for one more question?
No, we're out of time.
I'm sorry, David. Hopefully we can get to you later.
No problem.
Right. So our next presenter is Wu Ko. Wu comes to us with a Bachelor of Arts in Biological Sciences and a Bachelor of Science in Individualized Study from the University of Maryland, Baltimore County. Her concentration was child health, and her master's essay title is Breastfeeding Practices and Guidelines in High-Risk Pregnancies, a Scoping Review. Take it away.
Alrighty. Hi everyone, my name is Wu, and today I'll be presenting my master's essay, which was a scoping review on breastfeeding practices and guidelines in high-risk pregnancies. I do want to state really quickly that throughout this presentation, there are use of gendered terms within direct quotes, but I want to acknowledge that breastfeeding in pregnancy is not exclusive to a particular gender identity. Right. High-risk pregnancies is defined by the NIH as a pregnancy that threatens the health or life of the mother or a fetus, and reasons for high-risk pregnancies can be due to pre-existing health conditions, lifestyle factors, or complications and conditions that are directly related to the pregnancy. I'm sure that for a lot of you here, you know that it's recommended for infants to be breastfed exclusively for the first 6 months of life. And this recommendation is synonymous among the CDC, US Dietary Guidelines for Americans, the American Academy of Pediatrics, and the WHO. And this is because of the proven benefits for both the breastfeeding person and the infant. And this includes lower risk of breast cancer, ovarian cancer, type 2 diabetes, and high blood pressure for the breastfeeding person, and lower risks of asthma, obesity, type 1 diabetes, and sudden infant death syndrome for the infants. So this information was provided by the CDC, and one thing that I wanted to note was that within this general fact sheet that the CDC provided, there was no information or direction to other resources regarding breastfeeding for those with high-risk pregnancies. And you can see that through the image on the right side of the slide. And this led me to think about the experiences of breastfeeding for those with high-risk pregnancies. So in a retrospective study conducted in 2016 among high-risk obstetrical patients, they found that for the patients who intended to breastfeed exclusively, by the time that they were discharged from the hospital, 28% of those patients failed to initiate breastfeeding. And in a different study looking at breastfeeding promotion among pregnancies that were high risk for NICU admissions, 1 in 4 patients did not discuss any breastfeeding plans or make breastfeeding decisions with a provider during their perinatal consultations. So to me, it became evident that the breastfeeding experiences, including promotion, support, initiation for the individuals with high-risk pregnancies, were different from the general population, and suggestive that the availability and accessibility of breastfeeding guidelines could be a barrier to decide if they were going to breastfeed. And because breastfeeding recommendations for high-risk pregnancies were left out in the main CDC fact sheet, it was important for me to perform this scoping review of published breastfeeding guidelines and evidence-based recommendations to identify the people with high-risk pregnancies who can benefit from breastfeeding and should be encouraged to breastfeed. Without identification of breastfeeding recommendations in high-risk pregnancies, a group of pregnant people will be missed during breastfeeding promotion and support, and a group of infants won't be able to experience the benefits of breast milk. So in terms of the method for this scoping review, I followed the PRISMA scoping review checklist. And first I started off by searching PubMed, and I used key terms like pregnancy high risk, breastfeeding, practice guidelines as a topic, diabetes gestational. And I know they seem a little funny on the screen in the way that they're written, but this is the way that you would format it to search on PubMed. And then specific search strategies were also created with the help of the library informationist. I also expanded the search to include gray literature that might have been missed with the PubMed searches, and this was helpful in identifying reputable professional healthcare associations and their resources regarding breastfeeding and high-risk pregnant people. And I was able to look at information from the CDC, ACOG, American Academy of Pediatrics, and the Academy of Breastfeeding Medicine. So the diagram on the right, it might be a little small, but that kind of just breaks down how each round of screening eliminated papers from both PubMed and the gray literature. So once the search yielded results with peer-reviewed papers written in English and published within the last 10 years, an initial content screen was conducted. So the initial screen refined results based on the title and abstract to only include papers about high-risk pregnancies and breastfeeding. And further screening took place with a detailed review of the body of the paper to ensure that all case studies were removed, papers with broad recommendations were removed, and papers published within the last 10 years but with outdated guidelines were removed. So this resulted in having 20 papers from both PubMed and the gray literature together, and then data was collected about key details on the high-risk pregnancy condition and the breastfeeding guidelines. So the results yielded 14 different high-risk pregnancy conditions that could be organized between 3 categories of breastfeeding recommendations. And these categories were breastfeeding is not recommended, breastfeeding is recommended, and breastfeeding is recommended but dependent on the medication. So high-risk pregnancies that were identified where breastfeeding was not recommended was for infants with classic galactosemia, human T-cell lymphotropic virus type 1 and type 2, and Ebola virus. And in cases of human T-cell lymphotropic virus type 1 or type 2 and Ebola, breastfeeding was not recommended in order to decrease the risk of transmission of the virus to the infant through the breast milk. In high-risk pregnancies where breastfeeding was recommended, this included adolescent pregnancy, diabetes, and hypertension. And in cases of diabetes, there are proven special benefits to the breastfeeding person, such as having a lower risk of developing type 2 diabetes, because when lactating, the body has an improved ability to process sugar and insulin. And the third category was high-risk pregnancies where breastfeeding was recommended, but dependent on the medication and the therapy used by the pregnant person to manage their condition. And this category was focused on the risk of the infant absorbing that medication through the breast milk and the adverse outcomes when that medication was absorbed. For most of these conditions, there are medications that have been established through research to be either considered safe or unsafe during breastfeeding. So for example, those with lupus, prednisone is highly compatible with breastfeeding, but medications like mycophenolate is considered unsafe. But within this group, a unique category is HIV, maternal infection of HIV, and there have been recent updates to the CDC guidelines that indicate that it's actually safe to breastfeed if the pregnant person is on a antiretroviral therapy and sustains an undetectable viral load throughout breastfeeding. So moving on to the discussion, this scoping review revealed that breastfeeding is in fact beneficial and recommended for most high-risk pregnancies, and that most commonly recommendations were not about the condition that made the pregnancy high risk, but rather about the medications that would be taken to manage and treat the high-risk conditions. And this kind of acknowledged that medications play a huge factor in breastfeeding decision-making. And it's also important to acknowledge that there are high-risk pregnancy situations in which breastfeeding have special benefits to the breastfeeding person in managing their conditions, just like we talked about diabetes before. And this is the same with hypertension and also possibly with multiple sclerosis. Pregnant people with multiple sclerosis are recommended to breastfeed, and they might find it favorable to exclusively breastfeed because there may be a delayed relapse of MS due to a protective factor of breastfeeding. And when looking at the language, something that I saw was that the language varied across the different records, and it can be apparent why guidelines and recommendations about breastfeeding may not be clear to the clinician or the pregnant person. So for example, stating that a medication is theoretically safe may not increase confidence in decision-making in comparison to a phrase like breastfeeding should be encouraged. It's possible that clinicians will err on the side of caution when discussing breastfeeding due to the variability in the language used among recommendations. And it's also important to note the burden imposed on the breastfeeding person in situations like an HIV infection, where the breastfeeding person will have to be regularly monitored, which is an additional thing to do in order to determine if the viral load remains undetectable. So limitations of the scoping review are that some of the most common high-risk conditions were not included, like obesity, infection, multiparity, and there was also no discussion between the difference of breast milk and express breast milk. Barriers that prevent people with high-risk pregnancies from breastfeeding exist, and further research needs to be conducted in order to provide specialized breastfeeding support and education. It's also important to acknowledge that breastfeeding is not a single event, and the health status of the pregnant person can change, impacting their ability and their decision to breastfeed. And I just want to say a huge thank you to Dr. Gross, who's my advisor and was my primary reader throughout this process.
Questions? Great job, Lou. So, all right. Trying to get. Are there any questions for Wu? There's a lot of positive response. Any questions? I have to say that this was a really great topic for the moment, that it's timely, that some breastfeeding recommendations are being changed. In fact, some changed as Wu was doing their review. So it is a group that of people who may not receive encouragement or promotion of breastfeeding who may benefit or at least need advice. So good job, Wu. I thought that was really timely. Any questions?
We're assimilating all the information you gave us.
So Wu, you didn't, oh, Mary Catherine, did you want to ask a question?
No, just got here, sorry.
Okay. So I have a question, and I just want you to emphasize the language part, that you did actually data collection on the recommendation language, and do you want to comment on that a little?
Yeah, so the secondary objective for my scoping review was to look at the variability in the language used to describe the recommendations to see if that would impact how that information was relayed from clinician to patient. But because of time limitation, I just didn't really talk about that too much. But there was, throughout pretty much all of the sources, the language used was different. And so some authors would choose to say that this medication, there were no contraindications, or some people would say breastfeeding is encouraged, or breastfeeding should be recommended, or on the flip side, not enough data to support that breastfeeding is safe, so breastfeeding is not recommended. So from looking at the results of my secondary objective, there was a lot of variability in language, so that could be interpreted differently, and that can impact the confidence in when sharing this information to the patient. And then something that I also was looking at was whether this information was public or private facing. Is this something that just the clinician can interpret and then share with their patients? Or is it something that the pregnant person can also look on their own and then use that language and the variability in language to decide to use for their breastfeeding decision making?
Thank you. If there's no questions, I think we'll just go on, but good job, Lou. All right. So our next presenter is Alexa Bond. Alexa comes to us with a Bachelor of Science in Health, Society, and Policy from the University of Utah. Her area of interest is child health, and her master's essay title was Post-Dobbs Reproductive Landscape, Addressing Maternal Morbidity and Mortality Alongside Restricted Abortion Access in the United States. So take it away, Alexa.
Thank you for the introduction, Susan. With that, I will just jump right in. Go forward. A quick overview of what we'll cover. So first, I'll give some definitions and statistics. Then we will talk about how the social determinants of health influence abortion and maternal care access. Then we'll talk about the impact of the Dobbs decision, and then I will give specific recommendations on how to address this issue. And as a quick disclaimer, women is the broadly used term in the majority of the literature I use in my research. So I will be using women to refer to people who are pregnant or could become pregnant, but it is recognized that not everyone in that group identifies as such. So I'm sure most of the people in this Zoom are familiar with the Dobbs v. Jackson Women's Health Organization case, but as a quick overview, this is the Supreme Court case that reversed Roe v. Wade. And as a result, abortion laws are now determined by the states. So you can see on this graph that the red states are where it is restricted or illegal, and the blue and yellow states are protected or expanded access. Then on to definitions. Maternal mortality is death during pregnancy or within 42 days of the termination of a pregnancy due to pregnancy-related causes. And the total maternal mortality ratio increased from 17.4 deaths to 32.9 deaths per 100,000 live births in 2021. But this is contested, and it's possible that the issue is not intensifying at the speed estimated here based on how different measurements go. But regardless of if rates are rising so dramatically, the goal should be to have zero maternal deaths. And we know that an estimated 80% of pregnancy-related deaths were preventable from 2017 to 2019, which means that this issue is addressable. And then severe maternal morbidity, or SMM, are unexpected labor and delivery outcomes that lead to long or short-term repercussions for the woman. And there's no definitive list of these, but it is something like the need for a blood transfusion would fit into this. And in 2021, there were about 179.8 cases per 100,000 hospital discharges recognized using the CDC's classifications. But these rates are not equally distributed, and non-Hispanic Black women specifically are impacted at a much higher rate. They are 2.6 times more likely to die a maternal death than a non-Hispanic white woman. They're also more than 2 times more likely to experience SMM, and they have the highest abortion rate at 28.6 abortions per 1,000 women. And there's very little data on other race and ethnicity groups, especially Native American populations, though it can be presumed that they also face considerable barriers to maternity care and abortion overall. For example, the Indian Health Services is federally funded, so that doesn't cover abortion services, which definitely creates a barrier for that population. Most important to this presentation is that these disparities are anticipated to worsen as abortion restriction increases. So next we'll talk about the social determinants of health, which all play a role in one's access to maternity care and abortion services. And I'm only going to cover a few of them, and there's definitely not enough time to include the nuance of each, so this is just a very quick overview. So we'll start with education access and quality. In general, lower education is associated with higher levels of SMM and mortality, but large disparities still remain, as Black mothers with a college education are still more likely to die a maternal death than white mothers with less than high school education. Then going to neighborhood and built environment. An influencing factor here is maternity care deserts, which are counties where there are no maternity resources, including birth centers and obstetric providers. These are the red counties on the map, and the purple counties are where there's full access. And we know that states with restricted abortion access have more maternity care deserts at about 39% of their counties than states with expanded abortion access. About 25% of their counties are deserts. And we know that rural residents in general are also at a higher risk of maternal mortality and SMM than urban residents. And lastly, we'll talk about economic stability. So nearly half of abortions are received by women living below 100% of the poverty line. And the cost of abortion, in addition to transportation, missing work, and getting childcare, may not be feasible to align. And this goes for general maternity care as well. And there are also massive disparities here, as non-Hispanic Black families with the highest income levels are more likely to experience worse maternal health outcomes than white families with the lowest income levels. So with the Dobbs decision implemented, roughly 22 million women of reproductive age are living in restrictive states. And this is a bit of an older statistic, so it might be more by now. And the graph to the right was made before the Dobbs decision to illustrate maternal mortality rates by state based on whether an abortion ban was expected. So as you can see, in general, the states where a ban was expected on the left side have higher maternal mortality rates than where no ban was expected on the right side. And again, importantly to this presentation, abortion restriction is estimated to increase both maternal mortality as well as exacerbate existing disparities. So how do we address this? The ideal solution would be a federal reinstatement of the protections granted in Roe v. Wade, but given the current social and political climate, that may not be feasible right now. So to address this issue, there needs to be a focus on reducing the risk of maternal mortality in SMM and addressing the related disparities. So my paper focused on two methods. The first is to prevent unintended pregnancies by improving access to contraception, because we know that in 2019, roughly 34% of unintended pregnancies ended in abortion. So without access, more people are likely to have to carry their pregnancies full term and run the risk of experiencing maternal health issues. And the second suggestion is to screen for social determinants of health issues at the doctor to address these disparities. So for contraception, the two methods that we'll be focused on are long-acting reversible contraceptives, or LARC, which includes things like IUDs and implants, and then oral birth control pills. They're among the most common methods, but awareness of these methods is lower than that of other methods like male condoms, so there's a need for increased exposure and access. So for LARCs, this pyramid of access was made, and I'll start from the bottom up with the health system level, which includes cost and accessibility. LARCs are cost effective, but upfront cost is often a barrier for many, and insurers in 20 states and DC are allowed to refuse contraceptive coverage, so there's a need for health systems changes to address this. At the provider level, they include skill, knowledge, and attitude, and the main thing here is training. Training for providers is lacking, and one study showed that in publicly funded health centers in the United States, only 2/3 had staff trained in LARC and 1/5 of centers had no trained staff. So training needs to be more accessible, and in that training, comfort of the patient with a user-centered approach should be emphasized. Lastly, at the individual level, there is awareness, knowledge, and attitude. Awareness of LARCs is relatively low, so for implants, it's about 52%, and IUDs are higher at 87%, but methods like male condoms have 99% awareness. So making sure that people are aware they exist is a major key to provision. And next is knowledge. Women who are more knowledgeable about LARCs are more likely to consider the methods than women who are less knowledgeable. But going into attitude, even if patients are knowledgeable about the methods, they still may report negative attitudes about them. So as a whole, every part of this pyramid needs to be considered when expanding access to LARCs. Then next is oral birth control pills, which traditionally have only been available via prescription from a doctor. But now O-pill as a single hormone pill that has been approved for over-the-counter use by the FDA is in retail stores now. And this removes a lot of barriers individuals might face, like not having a primary care provider, not having time, having transportation difficulties, and other issues. However, because it is a progestin-only pill, it may not be suitable for everyone and their health needs. So to improve access further, more pharmacists should be allowed to provide contraceptive care and prescribe birth control. Currently, pharmacists can provide care in 28 states and DC. So the colored ones in the graph are where they can, and the gray ones are where they cannot. And you might notice that where they can't are often restricted abortion states, like in the South. So more states allowing pharmacists to provide prescriptions would remove the barrier to a doctor's office that many might face, and the above mentioned barriers. And lastly, as we discussed, the social determinants of health play a large role in the perpetuation of maternal health disparities. So this specific recommendation suggests that a screening be implemented for OBGYN and family practices for patients who are pregnant or capable of becoming pregnant. Although evidence for this practice is limited, it's a feasible strategy that could increase awareness of local services for those in need and thereby reduce disparities among those who receive care in the formal health system. And it's noted that this reach is a limitation, but it is a start. And we know that for many women, they are more likely to schedule and attend their child's doctor's appointments than their own. So including family practices helps us reach those women as well. And the example on the screen comes from the American Academy of Family Physicians, and it covers housing, food, transportation, utilities, and personal safety. And on the second page of it, the patients also have the option to either accept or decline help for this. And with this, providers could, they would have a list of local resources that would be developed before screening is administered so that they can quickly provide information and resources that a patient might need to help reduce disparities. So thank you for listening, and special thanks to Dr. Ann Burke, who was my reader throughout this process, and thank you to Dr. Susan Gross for being my advisor throughout my master's degree. So happy to take any questions.
Great job, Alexa. Any questions?
I have a question.
Go ahead.
It's actually sort of a vague question, Alexa, so I apologize. I was just very struck by the overlap between, and I already knew the overlap between the abortion restriction states and the lack of the maternal health deserts and the lack of oral contraceptives. What can we do? It strikes me that, you know, do you think that emphasizing the health of the mother is a way to go to start pushing back against some of the maternal health deserts and the oral contraceptive access?
That is a difficult question.
I know. You can just, you know, let's discuss. No, it's because it's like, how do you, in states with those many, that many barriers to women's healthcare, like, what do you do? And so from your reading, just, you know, ideas. I know there's no real one answer to this.
I think that you can also tie a lot of it back to like economic influences. And so if you say like, oh, these people are going to be more likely to be in poverty, more likely this and that, I think that is more of like a driving factor. Because I know that for another class, I was working on another like abortion related project from Utah. And that was like a big reason people there get abortions is for socioeconomic reasons. And so that's kind of what I used as like a backing to support that. So if not caring about the infant's health, then we can care about the mother's like social economic stability.
Yeah, that's actually a really good answer, Alexa, because it's another sort of, you know, I guess I'm sounding like strategic, but that is the strategy. If you want women's health to be better, infants' health to be better, how do we get these things passed? So thank you. Yes.
Yeah.
Broad ranging question. Any other questions for Alexa? Kristen, can I ask a question? Do we have time?
Yes, we have a minute, yes.
Okay. Alexa, excellent presentation. I have a question about the pharmacists. How comfortable are the pharmacists with providing prescriptions and contraceptive care? Is there any information on that?
I didn't encounter anything in my research. I didn't really go too deep into that, but I would imagine that most like, I know that like medical providers are interested in providing that. So I don't know how that carries over into the pharmacist world, but I would imagine they are interested. I guess it would depend on location.
I mean, I can add a little bit to that if people want, but I think one of the challenges has been some pharmacists are on board. Some feel like it's kind of outside the scope of the other million things they have to do. And I think another practical issue is, we as physicians sort of expect to get reimbursed for our visits and our time. And there's not a lot of, we had this conversation with some folks in Baltimore and Maryland a couple of years ago, that there's not a similar system in place for pharmacists to get any kind of reimbursement for the 20 minutes they might spend counseling somebody about some of these over-the-counter products or behind the counter.
Thank you for that.
Thank you, Anne. Any other questions? Well, good job, Alexa. We will move on to our last presentation. Our last presentation, but not least, is from Dorbor Tarley. Dorbor comes to us with a Bachelor of Science in Human Development and Family Sciences from Syracuse University. Her area of interest is maternal, fetal, and perinatal health, and her presentation today is Exploring Challenges and Opportunities to Enhancing Support and Care in Abortion Services, Evaluating Training Gaps, Counseling Disparities, and Referral Systems within Healthcare Assistance Programs.
Thank you, Dr. Gross. Good afternoon, everyone. I'm Dorbor Tarley, and thank you for joining me today. In this presentation, I will provide an overview of the following sections: background and context, training, counseling, referral systems, discussion, and conclusion. So let's delve into each of these areas to explore the challenges and recommendations in enhancing support and care in abortion services. In the ever-evolving landscape of abortion laws in the United States, abortion clinics serve as crucial entry points into the healthcare system. With 1 in 4 women in the United States expected to have an abortion by the age of 45, these facilities play a vital role in ensuring access to reproductive health care. Planned Parenthood stands at the forefront of this presentation with a multifaceted mission to provide comprehensive sexual and reproductive healthcare services to all individuals. This presentation draws from my firsthand experience as a healthcare assistant, referred to as an HCA hereafter, within the Planned Parenthood's abortion services. It aims to shed light on the multifaceted challenges encountered in training, counseling, referrals, and by evaluating the effectiveness of current practices and identifying areas for improvement, the goal is to contribute to the ongoing conversation surrounding patient care and organization mission alignment in reproductive healthcare settings. At Planned Parenthood, HCAs serve as the cornerstone of patient care, acting as the primary point of contact for both patients and the public. One encounter remains vivid in my memory involving a patient whom I'll refer to as Ashley, who arrived at the clinic during my first month there. Ashley was visibly anxious, and a younger patient needed space to discuss her experience with intimate partner violence and the reasons for her visit to the clinic that day. And while my job description outlined my responsibilities, nothing prepared me for the depth of emotion and vulnerability I encounter daily. And in Ashley's case, my role transcended mere counseling and procedural assistant and involved me offering to stand beside her during the procedure since she lacked the support person she desired and needed. Additionally, it entailed providing emotional support, addressing her concerns, and ensuring that she felt safe and cared for throughout her time at the clinic. This experience underscored the profound impact that HCAs have on patients' lives, emphasizing the critical importance of providing adequate support and resources for healthcare assistance within Planned Parenthood. The process of training for HCAs at Planned Parenthood comprised of 2 distinct phases: a video series with knowledge check-in questions, and then on-the-floor shadowing with experienced HCAs. And drawing from my experience and the best practices of effective training programs, I recommend implementing a structured and comprehensive training program supplemented by ongoing support and skill reinforcement. This program should incorporate a blend of online modules featuring knowledge check-in questions and an in-person facilitated training session that covers counseling techniques, vital sign and blood drawn assessments, and the utilization of electronic databases for record keeping. And to optimize the effectiveness of shadowing, I believe that regular check-ins by managers should be conducted to provide guidance and feedback. Additionally, Planned Parenthood can leverage staff meetings as opportunities to build upon the initial training provided. By implementing these recommendations, Planned Parenthood can establish a robust training program that equips HCAs with the necessary skills and knowledge while fostering continuous improvement and adaptation to the evolving landscape of abortion care. During my time at Planned Parenthood, I also observed gaps in birth control counseling that became apparent early in my role as an HCA. It wasn't until my second month as an HCA that HCAs received formal birth control counseling during our monthly staff meeting. This training proved to be effective and significantly enhanced our counseling techniques. The nurse practitioner leading the training emphasized the importance of shared decision-making approach, where providers serve as sources of method information, introduce the methods, and actively engage with the patients in the decision-making process. Based on that experience, I recommend that Planned Parenthood allocate resources for training HCAs specifically on contraceptive communication methods. Additionally, incorporating aids such as a comprehensive flowchart in the counseling rooms can further support HCAs in effectively guiding patients through their contraceptive options and decisions. Among HCAs at Planned Parenthood, there's also a noticeable diversity in the methods of delivering education about medication abortion, MABs, and procedural abortions, PAB. The diversity in approaches meant that patients encounter varying levels of interaction and the depth of information during their counseling sessions. And while individualized patient care is essential, inconsistent education delivery can result in gaps in patients' understanding symptoms and awareness. This underscores the significance of establishing a standardized and effective information provision protocol. And by acknowledging these differences in approaches and their potential impact on patient comprehension, there's an opportunity for Planned Parenthood to implement a more uniform approach to information provision. This involves conducting a needs assessment of the current HCAs to understand their preferences and factors influencing the choice between an informational pamphlet, a video, or a memorized discussion. And the findings from these needs assessment surveys could then inform the development of a concise one-pager that integrates essential information, ensuring that all HCAs provide consistent and thorough information to patients during counseling sessions, regardless of the information provision method. And the absence of formal or informal referral processes for abortion services within Planned Parenthood also became evident during my time there. The needs for referrals were particularly noticeable on second trimester days when patients seeking abortion services beyond Planned Parenthood's gestational limits were turned away without guidance or alternate providers or clinics in the area. Gaps in referral systems are also apparent during counseling sessions, especially in cases involving intimate partner violence and sexually transmitted infections testings. To address these deficiencies, I recommend that Planned Parenthood utilize patient waiting periods as valuable opportunities for essential service and resource delivery. And during these waiting periods, patients could be provided with a needs assessment and referral survey to identify their specific needs and preferences. And then HCAs can review these assessments and compile a personalized resource folder with pre-made resources. This approach not only ensures that patients receive the necessary information and support, but it also allows HCAs to tailor their counseling sessions based on the provided information, ultimately improving the overall patient satisfaction and experience. And while this presentation draws insights from my experience at one Planned Parenthood location, it acknowledges that the potential variation exists in HCA experiences across different locations. Nevertheless, the firsthand perspective offered here, particularly in the context of abortion care post-Dobbs, fills a critical gap in the literature by providing a valuable lens into the challenges and opportunities within the field. And given the interconnected nature of the challenges identified in training and counseling and referrals, it's evident that a holistic approach is needed for improvement. My initial recommendation would be to prioritize enhancing training protocols and actively involving HCAs in the development of a comprehensive referral service database. And by empowering HCAs with robust training and equipping them with the effective referral tools, Planned Parenthood can better address the complex needs of patients and further enhance the quality of care provided across its locations. In conclusion, HCAs play a vital role as the front line of patient care at Planned Parenthood, and as legislation surrounding reproductive rights continue to evolve, the significance of their work becomes increasingly evident. By identifying challenges within Planned Parenthood's abortion services and proposing actionable recommendations based on firsthand experiences, the aim is to enhance patient care. Effective training for HCAs not only enhances their confidence, but also facilitates smoother counseling and referral processes, which ultimately benefits both the patients and the organization. And having experienced the emotional and physical demands of supporting patients firsthand, I recognize the importance of organizational support for HCAs, and empowering HCAs with proper training, resources, and support enables them to provide efficient counseling and referral services, thereby advancing Planned Parenthood's mission of delivering high quality, inclusive, and comprehensive reproductive health care to all individuals, regardless of their circumstances. And I want to extend my heartfelt thanks to each and every one of you. And without your support, none of this would have been possible. So I want to thank my reader, Dr. Burke, and the Population, Family, and Reproductive Health Department. So that's Kirsten, Dr. Susan Gross, Dr. Blum, and Mary Catherine, my advisor. And then my Syracuse University advisors, Dr. Mulvaney, Dr. Lane, and Professor Cameron for coming out to see my presentation, and my friends and family as well.
Great job, Dorbor. So, is there any questions for Dorbor now? Let's go with Colleen Cameron first.
Oh, no, go ahead, Colleen.
Oh, okay. Dorbor, this has been very informative. I think traditionally the role of the HCA maybe has not been viewed as a psychosocial support person within the healthcare, the clinic setting and even just the training. How do you see an HCA different than other psychosocial support folks like social workers or case managers who might also be kind of thinking about that? How does the HCA really stand out in terms of the opportunity to provide psychosocial support compared to other professions?
I'm not too familiar with the day-to-day work of the social worker, but from my experience in the reproductive healthcare setting and from the experience that I've read in other care settings like palliative care and stroke care, the HCAs are doing that one-on-one intensive work with their patients, and they're usually following the patients from the moment that they're come into their like either the hospital or clinic setting until they're discharged. So I don't know if that's just similar to how social workers and other avenues work.
Well, it sounds like the opportunity to build a relationship, a rapport is really central here. Did you find that?
Yeah, I really enjoyed the opportunity, especially in counseling with my patients, learning a lot more about them and like what brought them there, especially with a lot of the questions we were told to ask the patients, just to personalize the experience more to make them feel comfortable before they got their procedure done. So I definitely experienced that.
Thank you.
Thank you.
I would ask, how long do you follow the woman following the procedure? Do you have a set period of time? And those, which I actually hadn't thought about before, those who cross into states because they can't get services in their own state, how long do you keep them in the service state before sending them back to a state where they couldn't get follow-up for this procedure, where it was illegal?
Yeah, so for if they come from out of state, one patient I had came from Dubai. So a lot of times we do a procedural abortion for them. So they're not allowed to do the medication abortion because they might encounter conflicts bringing the medication, since it's more of a 2 to 3 day process. And then in terms of how long we stay with the patient, we have two teams within at the Planned Parenthood location I was working at, where one team is counseling and then the other team is focusing on support during the procedure. But if you find that while you're in counseling, like the example I give, if you have a patient who feels very comfortable with you because of the counseling, they might ask you to stay with them throughout the procedure and come into the room and just support them that way. But usually you're with the patient for a couple hours.
I see. Do you have any overnight ability to monitor?
No, not at our location. We didn't have overnight abilities.
Mm-hmm. Yes. Thank you. Great presentation.
Any other questions? Dorbor, I have one. What was the retention rate of HCAs? Was there a problem with turnover? Was there a staffing issues?
Yeah, unfortunately, there was a problem with staffing and the turnover rate. I believe when I was there, the longest tenured HCA had been there since January, and I had started in August. So I think they don't seem to stay long, and a lot of them cited the reason was just like burnout and not feeling supported in the role. So that's what sparked this for me.
Thank you. Well, I want to thank everyone today for coming and to our 4 presenters for excellent presentations. We will have another session next Wednesday, May 15th, with more presenters.